I'm going to tell you a little bit about myself before we get started. I'm Leo. I work with the lung cancer screening program currently. I've been there since about June of last year. Prior to that, I worked with the heart and lung surgery team here at Holmes. My career has been mostly critical care. With the lung team, we obviously dealt a lot with the lung cancers and all, so that was my avenue to the program once we started the piloting process and getting it off the ground. On a personal note, my mom was a heavy smoker, and in 2008, she went for her routine health physical. In January, they did the chest x-ray. She was fine, she was good to go. And in May, about 4 months later, she developed crushing chest pain, so they rushed her to the emergency room. And during the workup, they did a CT and they found a huge mass in the middle of her chest. And how was that missed when they did a chest x-ray? She's a heavy smoker her whole life. At that time, they said 6 to 8 weeks without chemo, 6 to 8 months with chemo. And she lasted 15 months. She was with us, and she did great. She would go get her chemo, then go to the Hard Rock and play the nickel machines. And so she was full alive till the end. Back to the lung cancer screening program. We screen high-risk patients, predominantly heavy people that smoked heavily in their life, either currently smoking or former smokers. And I'll go over the specific criteria in a little bit. We promote heavily smoking cessation. And it incorporates, the nice thing about the program, it incorporates a multidisciplinary team, and that's a big word for saying that if scans come back positive and we do further workup, we meet about once a month right now, and it's a group of providers and doctors and specialists. It includes radiation oncology, medical oncology, pulmonology. Did I say radiation oncologist? So radiologist is there, pathologists are there. We put up the scans that are positive. They all sit there, and all these brains get together and say the best course of action is this, this, and this for this patient, rather than the patient having to go to one office and saying, not much I can do here, let's send we think we should go here and here and here. All the doctors get together, review the films, and say this is the best course of action. And that's one of my roles, is I put together that committee and present the cases, and then I help the patient navigate the system. And the benefit of that, what we're trying to do is cut the timeliness of care. So from diagnosis to treatment, if it's needed, we're trying to cut that time down so the patients get taken care of quicker. Lung cancer is the #1 cancer-related death. Prostate claims about 233,000, while breast is 232. It is the third most prevalent cancer type in both male and females, and it is the second most prevalent in both male and females. But yet, with those numbers, it is still the #1 cause of cancer-related deaths in the United States. And this screen shows that over 221,000 people are diagnosed annually with lung cancer. That's just our country. The American Cancer Society estimated in 2015 that all cancer-related deaths would equal about 589,000. And as the direct result of lung cancer, it's 158,000 annually. That was in 2015, and I believe last month they came out with new numbers, and I'll pull those up. But they're going to be pretty similar. So you can see that lung cancer claims more than any of them. 1 in 13 men and 1 in 16 women will develop lung cancer. Combined, 89% of all lung cancers have a smoking history relation. People who have never smoked account for about 20 to 30,000 of those diagnosed every year. And again, remember, there's 221,000, so that's roughly about 10%. Smoking is the leading risk for lung cancer. There's other causes that have been linked to it, like secondhand smoke, asbestos, air pollution, diesel, arsenic, and then there's some other metals, cadmium. I have them listed in my office, but still the predominant cause of lung cancer is smoking. And again, the program heavily promotes smoking cessation, and if you smoke or you have a loved one or someone you care about that smokes and you want more information on smoking cessation, we have a lot of information to help people quit smoking and kick the habit. And a lot of the information is free. There's free classes where they offer free aids like the lozenges and the gum. I'm going to talk about 5-year survival rates, and what that is from diagnosis 5 years later, are you still going to be around? Right now, prostate cancer, it's a 99% chance that it's good. The 5-year survival rate is 99%. Breast cancer is 89%. Lung cancer is 17%. They don't have colorectal cancer on this, but it's 65% for colorectal cancer. So it's a huge difference between the other cancers. And why is survival with lung cancer diagnosis so much lower than all the lung cancers? And we'll get into that. Lung cancer is typically diagnosed at a late stage. Most patients they have no symptoms until it's too late, like my mom, the crushing chest pain. And a lot of that has to do with there was no screening mechanism until recently for lung cancer. You know, with breast cancer, we have the mammograms, prostate PSA, colon, the colonoscopy, and it wasn't until just recently that studies were done, and that's when we started with the low-dose CT. And if you can see this graph, it depicts like the later it's diagnosed, the prognosis isn't good. The survival rate drops down to 1%, 9%, versus getting it caught early, it's up there at 49%. So it behooves, you know, our population and our folks to get diagnosed early and get it taken care of because you have better outcomes. This is what changed everything. It's the National Lung Screening Trial, and it was this huge study. They screened over 50,000 patients that fell in that high-risk category. They screened a portion with them with the routine chest x-ray and a portion with the low-dose CT. And what they found is by using the low-dose CT, we were able to pick up small nodules and cancers early. And it showed the numbers, mortality decreased by 20%. We saved that many more lives in that study. The study was so successful, they cut it short. It was published. And then the United States Preventive Task Force, and I'm jumping ahead of myself. Let me go back to that 20%. 20% decrease in mortality is huge. If we apply that to that 158,000 of the mortality rate for lung cancer, that's a big number. That's like 31,000 lives that could have been saved just last year in 2015. A lot of organizations are in support of the low-dose CT, and they're listed here, and it just keeps growing, the list of organizations. These are professional affiliations that are promoting the lung cancer screenings. When this study was published, the United States Preventive Task Force, and they're the ones that give us as providers our guidelines as to colonoscopies and mammograms and all that. They gave it a recommendation B, which is up there, which means that under the Affordable Care Act, it's covered by Medicare if you fall into the qualifying criteria and you meet all the criteria. So it falls up there. Once that happened, Medicare said, yep, of course we're going to do this. Last year they issued the fee payment, and patients are getting screened, and we're starting to catch it. And the hope is, historically, the stage 4s are way up here in diagnosis. If you look at the benchmarks in Florida, nationwide, Brevard County, stage 1s are down here. We're trying to reverse that. Let's catch more stage 1s and treat those patients and the folks. And let's drop those stage 4s. And we're getting there, little by little. Now, to get screened for lung cancer, a lot of the criteria, we don't make this up. This is stuff that Medicare put out there and said they have to have this to fall in order to qualify for it. And this is what the Medicare and most insurance companies, what they follow. 55 to 77 years old, either currently smoking or quit in the last 15 years. And history of smoking, a 30-pack year history, and there's a calculation we use for that. It's briefly described on the bottom. A pack a day for 30 years is a 30-pack year history. A pack and a half for 20 is 30. A pack and a half for 30 would be 45-pack year history. And I will tell you that I've had a lot of folks that have, well, not a lot, I've had a handful of folks that have come to me and said, I don't have a huge smoking history. I smoked for 15, 20 years. But I worked in asbestos. So I code it that way, and I push it forward, you know, and I do what's called a peer-to-peer with the insurance company, and they've been, you know, they approve it. They look at those on a case-by-case basis. If somebody does not fall strictly into that criteria, The other option is the test is offered for a flat fee of $99 because it's so important. You know, we're looking at numbers. Somebody smoked for 28 years, Medicare might come back, or 28-pack year history, Medicare is probably going to come back. No, they don't qualify. Well, we still, you know, I can't say do it, but 99 bucks. I know if it was me, I'd be under that scanner. If you quit smoking within the last 15 years, go ahead and start getting screened. And what happens is when your first results come back, we use, there's a grading scale that the radiologist uses, and we use to see if you have nodules. Sometimes we have to repeat the scan in 6 months, sometimes it's a year. So it's on a case-by-case basis. Because a lot of times on the scans, we can tell it's probably benign, likely benign, but let's watch it. Sometimes it requires closer monitoring, sometimes a year suffices. This is my contact information. We have a scheduler here if you want to stop by and see me to see if you qualify and do the necessary paperwork and all to get the authorizations and all for the lung cancer screening. Feel free to call me. Share the information with your loved ones who smoke or used to smoke. Send them our way. They don't have to go through their providers. They can just call us directly. And I do share, once we do get, you know, when we do the screenings, I will always ask, do you want the information shared with your primary care provider? And we do share, you know, very good communication across the board so that they're in tune with what's going on. All right, well, thank you for having me.